Good evening, everyone, and thank you for joining us for the HIV PrEP Forum. Before we get started, I would just like to acknowledge the traditional custodians of the lands on which we all meet and pay my respects to the elders, both past and present. So I would now like to introduce you to our presenters for this evening's session. Dr. Vincent Cornelise will be our facilitator tonight. Vincent is a staff specialist in sexual health medicine at Kirkton Road Centre and a New South Wales Health Conjoint Senior Lecturer at the Kirby Institute, UNSW. We also have Dr. Catriona Wee with us tonight. Trini is a director at Clinic 16 at North Shore Sexual Health Service, Northern Sydney Local Health District. Dr. Miriam Grotowski is a GP at Smith Street Practice in Tamworth. Miriam is also a senior lecturer in medicine at the University of Newcastle Department of Rural Health. We also have with us tonight Paolo Polomeni and Ferry Lowe, who are both PrEP consumers speaking to their experience being prescribed PrEP. So before I pass you on, I just wanted to note that this training has been developed in partnership with the ASHM and the New South Wales Ministry of Health. So now I will pass you over to Vincent, who will take us through the learning objectives.
Thanks, Bethany. So as you can see on the screen here, let's hope that by the end of the CPD activity, you can discuss recent updates to HIV pre-exposure prophylaxis, including how to prescribe and also the broadening of suitability criteria that came in with the most recent update to the guidelines, which were designed to increase access to anyone who is at risk of HIV. Second objective is to develop confidence in PrEP prescribing or follow through sharing of GP experience and patient experience and specialist advice. Thirdly, to discuss methods to overcome perceived challenges or barriers to prescribing PrEP. And finally, to identify tools and resources available to support PrEP prescribing in New South Wales. And as Bethany alluded to, we'll at the end give you a summary of all the tools that are available, and those will be emailed to you as well. So as you can see on screen here, there's a poll which we would love if you could try and quickly complete for us, just to really get an idea of where each of you are at in terms of PrEP prescribing. So firstly, just asking, how confident do you feel in prescribing PrEP? And then the second question is, what are the main challenges you have experienced when prescribing PrEP? If you can please all just tick those boxes.
I'll give you a few more moments.
Thanks, Beth. Can we share those findings?
Yes, I will just give them a few moments as we've got a few more people voting still.
Now we have a chat box on Zoom as well, which I'm sure you're all very familiar with because I'm sure you're all experts at Zoom now. Feel free to type any questions or comments in that chat box, and we are going to try to keep an eye on that during tonight's session. And as Bethany alluded to, we're really keen to try and keep this as interactive as possible. I'm sure some of you are very experienced at prescribing PrEP, some of you may be less experienced. So we're really keen to address any of the concerns or questions that you might have tonight. So here we go, is the results. So half of you are somewhat confident and the remainder is somewhat split between not confident and very confident. So we'll make sure that we cover the PrEP basics tonight quickly as well to try and get everyone up to the on the same page basically around PrEP. And then in terms of the main challenges, firstly, one that rated fairly highly is that you don't know much about PrEP, and we'll certainly aim to address that tonight. So hopefully by the end of tonight, you'll know a lot about PrEP. And the second one that rates highly is that you don't prescribe PrEP often enough. And we can talk about that as well. Because certainly, as I said, with the broadening of the guidelines and the broadening of the eligibility criteria, there is more opportunity to prescribe PrEP for patients who may be at risk of HIV. Great, so we'll move on to the next slide. There's just a small number of didactic slides that we're going to run through. Again, like I said, just to get everyone on the same page. This is the New South Wales HIV data from 2008 to 2020. As you can see, the overall, since about 2012, the overall HIV rate in New South Wales has declined from a high of 413 new cases in 2012 to a low of 206 cases in 2020. Of course, we need to keep in mind that the 2020 drop from 2019 is likely to have been affected by COVID. There was a significant reduction in HIV testing during COVID because people found it difficult to access testing services. Most of that drop has been attributed to the introduction of PrEP. So it's important to recognize that PrEP has had a significant impact on reducing HIV transmission in the community. Let's move to the next slide. This slide is quite famous. It was presented at a HIV conference a few years ago by Professor Holt. And it's affectionately known as the rainbow slide. And this is really looking at what HIV prevention strategies gay men are using. And this is from 2015 on the left through to 2020 on the right. And as you can see, the yellow area is people taking up PrEP as their main HIV prevention strategy. And that's really expanded quite significantly over those 5 years. And we've had a really impressive uptake of PrEP amongst gay men in Australia, particularly when compared to other settings internationally. It's been, and that's been the result of really close collaboration between the gay male community and the community organizations, as well as the medical profession and public health. Let's move on to the next slide. And if we, again, looking at new HIV infections a bit more closely in New South Wales, again, we're seeing a reduction. It's quite a squiggly line, so it's a bit hard to see the trend, but there is definitely a reduction in HIV diagnoses, particularly the darker blue line is early HIV diagnoses, as opposed to people who are diagnosed late. And of course, the reduction in early HIV diagnoses is much more likely to be the result of PrEP rather than the late diagnosis, because if someone's been living with HIV for several years, unfortunately, we wouldn't have been able to prevent that with the introduction of PrEP in recent times. So next slide, please. So just to go through some of the changes in PrEP prescribing, and I guess for those of you who are less familiar, to set the scene prior to these changes, when PrEP was first introduced in about, I believe it was 2014, or it might have been 2013, time flies, it was really targeted at people who were at quite high risk of HIV infection. So these were men who have sex with men, particularly those who, obviously all of those who were HIV negative, and then particularly men who have sex with men who were diagnosed with syphilis or anal gonorrhea or anal chlamydia, or men who have sex with men who use crystal methamphetamine, and particularly who use crystal methamphetamine in the context of sex, and then often had sex without condoms. There were some other risk categories, for example, trans and gender diverse people who met those criteria, and heterosexual people who were considered to be at high risk of HIV. That was a few years ago. As I said at the start of this talk, those criteria have now been broadened out, and now really anyone who's at some risk of HIV is eligible for PrEP. And in addition to that, it's recognized that some people might find it uncomfortable or might be hesitant to disclose their HIV risk when they come in to a doctor's surgery. So if anyone who comes into a doctor's surgery and asks for PrEP, they should be assisted to access PrEP without needing to further disclose their risk. And again, this is aimed at reducing barriers to access. So really trying to make it as easy as possible for people to access PrEP. The other changes are that PrEP is now a PBS restricted benefit rather than a streamlined authority as it was at the start. And the other big change is that a new PrEP agent has come on. So that's tenofovir alafenamide or TAF combined with emtricitabine or FTC. That's a slight change from what we've previously used, which was tenofovir disoproxyl fumarate or TDF and emtricitabine or FTC. I guess we can talk about this later if anyone's particularly interested, but I think for your purposes, for anyone who's less familiar with PrEP, The main agent that we use is TDF-FTC, or previously known as brand name Truvada, which is PBS listed. But TAF-FTC is TGA approved now, but not yet PBS listed, but we can talk about that later. It's been highlighted in the guidelines that we must consider actively promoting PrEP in underserved communities. So these communities are currently not particularly accessing PrEP, but we are seeing increased HIV diagnoses in these communities. So that's people from culturally and linguistically diverse backgrounds, Aboriginal people, people in rural and remote locations, non-gay identifying men who have sex with men, and this highlights the importance of taking a sensitive sexual history when seeing clients, because not every man who has sex with men identifies as gay and may not readily disclose same-sex male practices to you. At-risk heterosexuals, young men who have sex with men, and men who have sex with men who live in areas with low concentrations of gay identified men. So these population groups really would benefit from more active promotion of PrEP, particularly by their GPs, which is of course where you guys come in. So let's go to the next slide. And here we go. We're now going to talk about patient experiences. So I think, Paolo, it's over to you first.
I may start introducing myself, if that's okay.
Yeah, if you could.
So that gives you a bit of time. So, hi, my name is Paolo. I'm 48 years old, gay man. I grew up in Italy. I've been in Australia for about 20 years now, and I'm doing some health promotion work with men who have sex with men these days.
Thank you, Paolo.
I can, if you want me to start, I think you wanted to ask me something about my experience accessing sexual health and care back in Italy.
Yep.
I'll start with that. So look, in terms of my experience with sexual health and care back in Italy, it is quite different from what we have here and what is like today. So first of all, I cannot recall any sort of education or campaign sort of thing happening back in Italy in terms of sexual health at all. If anything, I remember a strong campaign against the use of condoms, so probably pretty much kind of the opposite of what it should have been. Obviously, there was a big influence from the Catholic Church, and even at school, we were told, even by our teachers, we were told that using condom is a sin, we should not use condoms, pretty much. In that environment, I remember members of parliament and ministers saying that gay men are pedophiles, so they should not be allowed to work with children, these sort of things. So that is the environment I grew up in, talking about 20 years ago, as I hope things are much better now. But one thing I recall is that when I was in high school, at my very last year, a very courageous editor of a famous comic those days decided to initiate this just a one-off sort of campaign by telling young people how to prevent HIV by using condoms, considering that HIV was prevalent in people in their early 20s those days. And so they couldn't print this as they would normally do and have it in a news agency. So they printed this strip, organized a massive number of volunteers going to high schools in one day to distribute this strip. It was a very cute and funny strip with a sexual health promotion message. The Ministry of Education sent an army of police to every high school to confiscate this strip, and I wasn't even lucky enough to actually even see it. So this is the sort of sexual health campaign and messages I was getting those days, so quite different. In terms of testing, it wasn't a very easy experience. I was about 30 years old. I could not see my family doctor because I was afraid of my doctor possibly telling my parents that I was gay, and I wasn't not allowed to let my family know. I was afraid of my father, who would probably have kicked me out of my home, and I was afraid of losing my jobs, maybe friends, and it was a very sort of scary scenario. So one day I was traveling to Rome and I decided to be brave, go to the hospital and get this HIV test done. And it was a very, very difficult sort of situation at that point. So I was talking to this doctor about disclosing my sexuality, which was an easy thing to do those days for me. I've been called homosexual by the doctor, and I was actually I had to define myself homosexual as a requirement to get that test, which is a word I didn't like, I don't like, but I had to use it on myself to be eligible to the test. There was a very detailed terminology that was quite uncomfortable to me. And the doctor, since I disclosed my sexuality, didn't look at me anymore for the entire conversation. Has been looking at the floor rather. So that was my very first and last HIV test in Italy. I was lucky if I didn't catch HIV in Italy because I wasn't really far away from any sort of education and information at that point. And I must say the fear of that sort of behavior and sort of the stigma kept me away from the services from that moment on. So I guess, that is a very, very, very difficult experience from what anyone will experience today in Australia. But I guess it kind of is good to have an idea of what people have in their minds when they come and talk to their doctor sometimes, especially if they come from overseas, and they may have experienced something similar in their own country.
Thank you very much, Paolo. Thank you for sharing your experience with us. Just because I'm aware of time and we are a bit tight on time tonight, so I'm just going to move on to Ferry. Ferry, would you mind introducing yourself to tonight's group?
Sure. Okay. Thanks everyone for having me. First of all, my name is Ferry and I'm 32 years old and I'm from Indonesia, but my background is Chinese, so you can call me Chinese Indonesia. And I've been living in Sydney for 4 years, so I think I'm the recent migrant. And previously, I lived in Jakarta, in the capital city of Indonesia, for 9 years. And I have been taking PrEP since 2018. So about 3 to 4 years now. And actually, I know about PrEP firstly from Grindr, which is the gay social app. And then the reason is because I think myself as a gay man, like I have a active sex life. And also at that time we had a research, so I was volunteering myself in participating the research from Kirby Institute, I believe. And yep, I think that's it. Introduction from me.
Great, thank you, Ferry. I was just, again, sorry, as you know, I accidentally asked Paolo this question, but because it is so important to get an idea of the challenges faced by people who've recently arrived in Australia in terms of accessing PrEP. And so would you mind sharing sort of your experience of what you found helpful or less helpful when trying to access PrEP? You mentioned that you found out about it through Grindr. But in your interactions with medical professionals since then, what has worked for you and what have you found to be a bit of a challenge?
I think if you're talking about migrants, it depends on where they are from. From my personal experience, because Indonesia is like a majority Muslim, and it's a lot of like stigma and shame when you're talking about STIs or even like HIV. I think like people still think like HIV is like contagious and like a death sentence. And because most of people are religious, so it's always like related to like something like curse and like a bad people or maybe like a sex worker. So I think it's back again. If answering your question is, I think the hesitation, like because the culture back in home country make it like a shame to go to see doctors or accessing sexual health clinic. I think it's the mindset. So first of all, I think like ACON, I think is a really good organization that creates like a safe place, as in like a community for recent migrants, so they can like feel like unlearn all the shame and the stigma, and they feel comfort to start accessing and then finally to get like to get PrEP or even get regular testing. So I think like community and like organization like are really important to be like welcome to all the recent migrants to Australia.
Thank you, Ferry. And I think you already alluded to some of the difficulties that people face as a result of their own cultural background. Do you, I imagine you probably have friends from your own cultural background as well. Have they told you about any of their experiences, say, perhaps, because you mentioned ACON, which obviously is in the middle of Sydney, but do any of them live in sort of more outer suburbs, and have they found different challenges as far as you know?
Yeah, I think if you are talking about Sydney, like I know some friends who live in like outer Sydney, or maybe even like outer west. I think they also and especially coming from a certain background, I think they also like feel scared of getting all the information, and also they don't have like enough sex education and awareness. But ironically, they are still like engaging in very very active sexual life. I think, for example, like for me, like I always like to ask people like, oh, are you on PrEP and what's your status? It's just because like I want them to know that I'm on PrEP, I'm negative. And then like even some of them using the term like, oh, I'm clean. So like in that saying, if you say the opposite of clean is dirty, I mean like nobody wants to be said that he was dirty or something, but he meant that clean is like clear from STIs and everything. I mean, I get that, but I thought like that was such a bad term to use. But I also asked them like, oh, okay, so when did the last time you get testing? And they like, what kind of testing? So I try to say like, oh, did you get like a STI testing or HIV testing because you said you were clean? And they say like they were like thinking for a while, and they say like, oh, maybe perhaps sometime in last year. And then so like actually in my opinion, they don't have a regular testing is because they either don't have proper sex education, or also they feel scared. Also, as I see in Sydney, we are so concentrated in the city area, and I think in inner city. I'm not really sure if people who live in like outer Sydney, do they have like a proper sexual health clinic which they can access, or but they still could be like discreet to access to the sexual health clinic. So I think that's really important. I think even in Sydney, people from outer Sydney are actually I feel like there were like my friends who were from Indonesia, who were scared, who were like having no sex education, but still engaging actively in gay sex, and like having many multiple casual partners.
Yeah, I think you make some very good points, Ferry, and there are some very particular challenges to addressing HIV rates amongst people who are from different cultural backgrounds, which we'll touch on again. I'm just going to move along again for time to our next section. I've just got some questions for, I've got the poll up here again. So just to gather from everyone who's here tonight, how often have you prescribed PrEP? So if you can click on those buttons for me. And in the meanwhile, I'm going to move along and ask Miriam and Trini. Let's start, who's in my field of vision? I'll start with Trini. Trini, what would you say is easy about prescribing PrEP, and what successes have you experienced?
Well, the PBS listing has made it much easier. The fact that people can access it, even if they don't have Medicare, is also good. The personal importation has made it a lot easier for a lot of international students to access PrEP, and that's one group that we see a lot of.
Sorry, Trini, can you explain that a little bit more for the audience? Because people might not be aware about
so even if patients aren't Medicare eligible, they can still access PrEP. There are online sites where they can personally import generic medication, and this medication has been shown to be bioequivalent to the brand name. It's completely legal, and it works out to be much cheaper. So what happens is the patient goes online. There's pan.org, and I think we have a reference for that at the end of the slides.
Yeah, and people will be emailed.
Yeah, you go on that, you upload your script to the site, and you get sent it from overseas. And it works out to be, you know, only just over $20 a month. You can get all 3 in one go as well, all 3 months in one go, rather than having to get access 1 month at a time. The only issue is that you need to plan it in advance, because it takes a while for it to be sent, and it's unpredictable sometimes how long it takes. So that's very good. The fact that a lot of the PrEP information now is in other languages, it's not just in English, makes it a little bit more accessible to people. Successes we've had is it has allowed us to engage an at-risk group. So particularly those men who have sex with men who may not have come in for care previously are now coming in because they're getting their PrEP scripts and they're having routine screening. So that's definitely a plus. It gives you the opportunity to implement other harm minimizing issues. So things like hepatitis vaccination, hepatitis A and B vaccination. You get to screen people. You get to talk to them about their partners, keeping safe, other concerns to do with STIs, and you know, things like needle exchange, Hep C risk. So it allows us to talk to them about those sorts of things. And it's a good opportunity to talk about other options. So treatment of prevention for people who are already HIV positive, educate people about the real risks of HIV, talk to them about condom use, because people sometimes still use condoms, strangely enough. And also we've also identified some very early infections. So people who are HIV positive who would not have gotten testing otherwise, but they've come in because they want PrEP, and we've screened them. So it's really good.
Thanks, Trini. Miriam, did you, from a GP perspective, any particular challenges or successes that you wish to share with us tonight?
I just think one of the successes I talk about is the fact that we actually have, my experience in my own community is the person coming in and requesting PrEP. So the community themselves being informed and being confident enough to come and ask me to prescribe PrEP. So that's been a really positive success story. Like Trini, the opportunity when people do present to have conversations about ongoing safe practices, but also offering general screening tests that they may not have turned up for, except that they're after PrEP. They've heard about it through online sites or through their mates. So I think that's been a really positive success. I guess one of the challenges I've faced as a rural GP is people knowing that they can come and approach any GP for PrEP and making that widely known. I think that's always a challenge, but something that we really can overcome quite easily, because one of the things I do find whilst I'm an infrequent prescriber is following the clear steps that are on the New South Wales decision making tool, the ASHM tool, makes such a difference. And I can just do what I do with lots of things in general practice. As we know, we're jack of all trades, masters of none, but we keep resources handy. And those sort of tools mean that if someone approaches me for PrEP, I can look that up at the time and feel confident that what I'm doing is up to date and easy.
Thanks, Miriam. I'm just going to see if we can put that tool up on screen, because it is very handy. And I think this is particularly important and as this come up in the chat box a little bit, is that it's and as you said, no, it's very difficult to remember what you need to do in these sort of scenarios when you don't routinely prescribe PrEP. So here you go, you can all breathe a sigh of relief. There is a tool available online from the Australasian Society for HIV Medicine, which very easily, in a step-by-step fashion, explains to you how to prescribe PrEP. So you literally walk through these steps. As you can see up here at the top, it's 1, 2, 3, 4, 5, tells you what you need to do at each step. For those of you who are less familiar with PrEP, I'll just very quickly run through it. Step 1 is identifying that someone needs PrEP. So either they come to you and they ask you for PrEP, or you've identified from your consultation with them that they would benefit from PrEP. So for example, they might disclose that they use substances, particularly crystal meth in the context of sex, or you've diagnosed them with a sexually transmitted infection, and you go, hang on, I think you're at risk of HIV, let's do something about that. So that's step 1. Step 2 is working out whether they're clinically suitable to have PrEP. So you do a HIV test, make sure they don't have HIV already. You check their kidney function tests, and basically, so if they're HIV negative and they're at risk of HIV, then they're clinically suitable for PrEP. And then, sorry, I was getting ahead of myself. Then step 3, you move through and you need to, oh my God. So you do kidney function tests, make sure they don't have renal impairment. And that is probably, we used to be really worried about renal function tests. When we first started with PrEP, we were really worried that we would see renal toxicity from PrEP. That's because the tenofovir in the PrEP medication can potentially be renal toxic. But I would like to stress to all of you that experience has shown over the last few years, and having had thousands of people on PrEP around the world, well, if not hundreds of thousands of people on PrEP around the world, that renal toxicity has not borne out to be a major concern. So we certainly still do a renal function test at the start, and then we do that every 6 months while someone's on PrEP. But please don't feel afraid to prescribe PrEP because you're worried about renal function and renal function risk. PrEP has shown to be a generally very safe intervention. The next step, step 3, is to do STI testing. And as Evan here in the chat box said, you know, what have we seen? Have we seen an increase in STIs amongst men who have sex with men attributable to PrEP? We certainly have seen a massive increase in STI screening amongst men who have sex with men, thanks to people being on PrEP. So that's been a big plus from a big PrEP rollout. And as a result of increased screening, we've also seen increased STIs. There have been quite some solid analyses looking at, you know, is this due to PrEP or is it because of increased screening? The jury is still somewhat out, but we've certainly, I think it's fair to say, we've not seen the explosion in STIs that some people were worried about. But certainly STI screening is part of the monitoring. Under step 3, it also talks about checking hepatitis B serology and hepatitis C serology, and then you just go on and prescribe the PrEP. So there will be a link to this in the email that you'll get, but it really makes it very easy. So I just wanted to highlight how easy it is to prescribe PrEP. You can all do it. And hopefully by the end of tonight, you'll all feel confident to do it. Trini, did you want to talk about the changes to PBS?
Yeah, so prescribing is now just a usual script. It's it used to be on authority, but it's no longer authority script, which makes it a lot easier. Any GP, any doctor actually in New South Wales, in Australia can prescribe. So it's much easier. They've also, the guidelines have relaxed, so you only need to have an HIV negative test sometime within the 28 days. So if your patient's not had a test recently and they've not had any high risk exposure in the last 72 hours, you can start prescribing PrEP and take the HIV test then and wait for the result. One of the initial concerns about doing that was starting somebody on PrEP who was already HIV positive, with the risk to development of resistant virus. But that's been shown to not be of concern, not significant. So as long as they're having a test at some stage, prescribe away. As Vincent said, it's really, really easy. As far as the renal issues go, we have hundreds and hundreds of people on PrEP, and we've had nobody who's had to immediately stop for an emergency renal issue. We've monitored people's renal function, and we've seen some, in a very small handful of people, their renal function drop. That's their eGFR. But once you remove all the other, some of these people are on enormous amounts of protein shakes and supplements, so they look like Dolph Lundgren, if you're young enough to remember, old enough to remember who Dolph Lundgren is. You know, so they look like they've got walnuts stuck under their shirt, sort of thing. But once you remove all of that, most people, the very, very large majority of people, go back to normal.
Thank you, Trini. Now, sorry, we had some, sorry, yeah, Beth, if you can share the poll results, that'd be great. So here we go, here's the poll results. 50% of you have never prescribed PrEP. That's very exciting. The reason I'm so excited about it is that hopefully after tonight, you will feel confident to do it and will soon prescribe your first PrEP prescription.
Maybe there should be a competition, Vincent.
Yeah, we should run a competition.
And the winner gets to listen to the webinar again.
But I get to host the next webinar. Miriam, just over to you again from a GP perspective. In terms of the logistics of doing this during a GP consultation, have you got some wisdom to share with us?
So I think that's right, isn't it, Vincent? One of the things that is often cited as a reason for not taking up something like PrEP prescribing is that we worry about time, but really it can be integrated into any consultation. So I think one of the most important ideas is that this can be done in 2 steps. So you can see the person, have the conversation. As Trini just said, if you feel that they are at risk and you can get an HIV test result in a few days, start the PrEP then and there, but get them back to have a talk, get the STI screening done so that you can talk about those results. So it can be divided from 1 consult into 2 consults, or you could, if you've got time, a longer consultation. I think the other one is, the other advantage is if you space the consultations, someone comes in and they're asking about PrEP and you're not sure, you can actually just pause, like we do for lots of our other consultations that we do infrequently, get the information in your hands and understand what you're doing before you pass that information on to your patients. And for example, you could call the New South Wales Sexual Health Info line then and there with the patient with you to ask the questions, or call your local sexual health clinic. Even though you may be in a more remote rural town, there will be a sexual health clinic somewhere in there's quite a few of them around the state. So you could call one of those to have a bit of a conversation and get some advice. So I think, you know, that we've got resources that we can use. We've got online resources, we've got on-phone resources, and we've got colleagues that we can call.
Yeah, thank you. And I agree. Phone a friend is always a good option, and people are certainly welcome to phone their nearest sexual health centre for advice as well if you ever feel like you're getting stuck. Great. So, sorry, I'm just having a look at if there's any questions coming in. So, Trini, have you? Sorry, I'm just going through. Just working out timing-wise, how are we going? So just going back to
I'd just like to, sorry, while you're looking at questions, I'd just like to reiterate what Miriam was saying. It is quite easy to streamline the PrEP issues. We have a cheat sheet that we use that we just tick off that we've done the test. We give the patient the request form and they go and do the testing. We don't need to have the results to keep continuing their PrEP. So it's just come in, how are things? Let's do your screen. Here's your script. See you later.
Yeah. And I think, in general practice, what I used to do was I had, all the general practice software has the capability of having templates, drop-in templates for your progress notes. And what I used to do, granted, I used to see a lot of PrEP, but I had a drop-in template for the first PrEP consult to cover all the things that I needed to talk to the patient about and the tests that I needed to do, and then a template for follow-up consults. And it does make it a lot easier. I'm sure you're all very familiar with that for lots of different conditions and lots of different plans for people's different health conditions. Miriam, is that something that you use?
Absolutely. So we have autofill set up, and I think for conditions that you're not doing frequently, those checklists can be most useful and just good reminders. You can also set up on your pathology an actual PrEP request, and you've pre-populated it with the tests that are required each time. So it again streamlines the consultation. So I think that's a very useful tip.
Yeah, thanks. Sorry, the reason I'm sort of scanning over programs that we've already covered a few of the things that we're going to cover. But Trini, we talked a bit about men who have sex with men from culturally and linguistically diverse backgrounds who may be less engaged with the mainstream gay community, and that results in reduced knowledge of HIV, as Ferry pointed out. Do you have any tips on how GPs can engage around this and what their role might be in this?
Yeah, definitely. The first thing is to be open to PrEP and to let patients know that you're open to discussing it and that you're willing to have that conversation and you're not going to judge. I mean, coming from different cultural backgrounds, people have different understanding about what the GP, what the medical system is. So navigating that can be very difficult to begin with, particularly when you don't speak the language. Knowing what to ask. There's also that fear of judgment and discrimination. In a lot of different countries, particularly I'm Chinese, the doctor is up here and the patient is down here. Now, that's very difficult then to go in and to ask for something or to discuss very personal information. So you really do need to be open, and even something as simple as bringing up the topic with your patient can really break the ice there and say, I'm willing to have that conversation and go there with you. The payment can be difficult as well. So alerting your patient that you're open to that discussion, and that might be as simple as just having a poster in your waiting room, having some flyers in the front desk. Word of mouth is really important as well. For a lot of our non-English speaking patients, we will say to them, if anyone you have sex with, if they're worried about HIV, they can come here as well. We have interpreters, blah, blah, blah. We can get phone interpreters. So that's not a problem. But for some of the cold backgrounds, they don't have Medicare, and we've talked about how to access that elsewhere.
Thanks, Trini. And Miriam, I guess over to you with this, because I imagine there's similar challenges in rural and remote communities around people finding it difficult to access HIV information or to know where to go with their HIV risk. Have you any wisdom you'd like to share with us around making this accessible for people in rural and remote communities?
Look, I think similarly to Trini, the notion of having posters up, having brochures in the waiting room highlights that you're open to conversations, being very clear and open to questions and picking up on cues that patients might give you is really important too, and non-judgmental language. I think one of my lessons over time I've learned is that knowing that sexual behaviour isn't always static and people may change between visits and have different notions about their sexuality that they're prepared to share with you as they get more comfortable with you. And I think it's really important to be open as a GP to such changes and just to use language that's very, very sensitive. I think the other issue in rural settings is around confidentiality. And in some ways, we're a bit privileged in general practice because someone can be coming to see us for any reason. So it isn't necessarily declarative that they're coming to see us for PrEP or for sexual health checkups or for HIV information. And that's a positive, I feel. The other one, though, of course, is being very, very careful with confidentiality, both within the practice and even in the greeting and the seeing out of patients. So I think those sort of notions can make it really important. I can't stress enough about the importance of being non-judgmental. And in our area, for example, we see a lot of Aboriginal patients. And I've had an Aboriginal health worker really reiterate to me over many years, it's so important not to use the excuse of not feeling comfortable or saying you don't know how to ask a question as a reason for not giving care. And that's so pertinent in a rural area because there may not be another place that person can go and get care.
Thanks, Miriam. And I guess, so there's a significant distinction between your setting and Trini's setting, where Trini works in a sexual health clinic, where people come in expecting to receive sexual health care. But as a GP, how do you, I imagine, and I've certainly found this myself when I was a rural GP, it can be difficult to ask the questions about sex and sexual history and work out whether someone indeed has a HIV risk to start with if they're not identifying that risk themselves. Do you have any quick, we don't have a lot of time, but do you have any quick tips for people on how to broach this topic?
I just think one of the important issues is to normalise the asking of the question, just to make it a normal part of general good health. So, you know, we ask smoking histories, we ask alcohol and drug histories, we also ask sexual histories, and we ask it in a non-judgmental way, and we ask it regularly of patients so people get used to it. So that would be my biggest tip overall. The more confident we are that we're asking for reasons to give good health advice for a holistic approach to this patient's care, gives us confidence, and it will help the patient understand that we're doing this. You know, I ask all patients who come in these questions, would it be all right? That few of these questions are a bit private, would it be all right if I bring these up now?
Yeah, I think that's a really important point, Miriam. And I think I don't want to overemphasize this, but it's great that everyone's here to learn about PrEP. But if people aren't taking sexual histories routinely, then it's going to be very difficult to identify patients who need PrEP. So I think, sorry, that's why I just wanted to emphasize that. We've talked a lot about men who have sex with men. I just need to point out that PrEP is not only for men who have sex with men. PrEP is available for anyone who is at risk of HIV, and that may be heterosexual women, maybe heterosexual men, maybe trans and gender diverse people, and it may indeed be people who inject drugs who may be at risk of HIV. Now, in the PrEP tool that we pointed out before, there is some advice on which particular patient types would particularly benefit from PrEP. So I encourage you all to look at that tool when it gets sent to you after this workshop. Now, Trini, so just to move on to, we're just going to think about accessing PrEP for consumers. And we've kind of already touched on this, but Trini, do you have any thing to add on which communities or groups we see a lower PrEP awareness in your experience?
Oh, in my experience, it's definitely the non-English speaking people at risk. Also, people who are newly arrived from overseas. Students tend to be, a lot of the students around my area tend to be less aware, and people who are not as engaged with the gay community. So they don't get that those health promotion messages. So they may be people who identify as heterosexual, who have sex with men, for example, or from outside of the, I was going to say ghettos. That's probably not the right thing to say, is it? Outside of the inner city area. See, we're on the North Shore. There are very, and my area stretches all the way up to Hornsby, and there are areas within my local health district, such as Northern Beaches, around Hornsby, Epping area, where there are men who have sex with men and other people at risk of HIV, but they're not engaged with the gay communities, so they don't get that health messaging.
Yeah, all important points. And just quickly, because I would like to address some of the questions that are in the chat box. But before we move to them, Miriam, rural and remote settings, any issues with regard to getting access to the actual medication itself from your local pharmacy?
So in my particular area, there isn't. And I guess one of the ways of finding out is by ringing your local pharmacist and seeing who's got access to it. But if there were issues, and some of them might be around privacy, particularly in very, very small towns where the person wanting to access PrEP knows the pharmacist or is worried about the information getting out into the community and they wouldn't be comfortable with that. There's two ways of doing that. There's the online service that Trini mentioned, but the other way would be to use a pharmacy in another town. And we've certainly used those habits in the past for accessing medications for other reasons. But I think, you know, one of the clues I learned early on is just ring your pharmacist. Someone around will have it, someone around will be familiar with it because it's becoming more common.
Yeah. And, you know, if they don't have it, they can order it in, and usually pharmacists can get medications in within 24 hours by, you know, some way.
Absolutely.
I guess also it'd be sometimes, I think in rural communities, it is important to ring the pharmacist, not only to ensure that there's a supply of medication, but also to make sure that the patient themselves don't have a negative experience of going to the pharmacist to obtain that medication, particularly, as you said, when issues of confidentiality may be problematic in country towns. One of the questions in the chat box, sorry, we're going a bit off script here, but one of the questions in the chat box is from David. And David asks, and Trini, I'm going to throw this to you. David asks, can PrEP be taken daily forever? Ideally, it should be monitored, but if you know the patient will not come back, is it safe to give them a long-term script? How would you reply to that?
Okay, so look, it's thought to be the whole theory behind PrEP is that people take it when they're at risk, and that risk will change over time. So somebody might be out there, you know, there's no restrictions, there's no mask wearing, people going out, they're having fun and they're having a lot of sex, and then they meet somebody, or there's lockdown, so they stop. So it's thought that it because people's sexual activity is dynamic, that their PrEP use will change with that. It can be taken for ongoing without risk, as long as it is monitored. PBS wise, you can only give up to 3 months of medication at a time, and that encourages people to keep coming back for screening in particular and monitoring. And we're looking not only for HIV, we're also looking for STIs. I'd be reticent to give somebody a long-term script or long-term medication unless there was a particular reason. But at the moment, I can't actually think of one, given that nobody can travel anywhere. There are other ways to take PrEP also. Standard is daily. Anyone can take it daily, but if you're a cis man who has sex with men, so if you're the same gender, if you're a male gender and you're male gendered at birth and you only have sex with men, then you can take PrEP on demand. And I think we've got a video about that later on.
Yeah, I think the video will be sent out by email, but I guess just to point out that ASHM, the Australasian Society for HIV Medicine, has also produced a decision tool around on-demand PrEP for men who have sex with men, so which is also available on the website, and we'll make sure that that link is also included in the email that everyone will get. It's a bit complex to explain right now, but it is an option for, as Trini said, cisgendered men who have sex with men as opposed to transgender. Caroline said, is PrEP restricted to adults only, and would you prescribe it to a sexually active 16 to 17-year-old? Trini.
Okay, so no, it's for PBS listing. I think it's 18 years plus, but you can give it to younger people, depending on their size and weight. But definitely in a 16 or 17-year-old, you can prescribe it.
Yeah, exactly. There is some guidance on this in the PrEP guidelines. The main concern has been because tenofovir can have an effect on bone density, and there's just very limited data on bone density in people who take PrEP during the phase of bone growth. So 16 to 17-year-olds, but as you know, it becomes a risk-benefit calculation. If someone is at significant risk of HIV, it's better to prevent their HIV acquisition than some theoretical problem with bone density.
Interestingly, interestingly, there is PrEP data from case series and observational trials of PrEP in 12 and 13-year-olds plus. So I don't understand why a 12 or 13-year-old would actually need to use PrEP. I don't know. It sounds a bit awful, but there is data available.
Yeah. Bronwyn said if someone gets started on PrEP, on PEP from ED as a starter pack, can GPs prescribe PrEP to complete the course as 28 days, even if not on, even if I'm not an S100 prescriber? Now, I'm going to have a go at answering this question. As you hopefully all know, just background, there's PEP or post-exposure prophylaxis and PrEP or pre-exposure prophylaxis. PEP is reactive, as in if someone comes into an emergency department, for example, and they say, I had sex last night without a condom or the condom broke, I'm really worried about HIV. Depending on the exact circumstances, they may be started on post-exposure prophylaxis, which is a course of 1 tablet a day for 28 days for most people. For some people, it might be 2 tablets a day. Now, for most people, as Bronwyn said, it's Truvada, 1 tablet a day, which is the same tablet as PrEP. So the guidelines do say, and the new guidelines emphasize more strongly, that you as GPs can prescribe PrEP as PEP. So if someone comes to you and says, I had sex last night with a new sexual partner, I'm worried about HIV, and you have a talk to them and you work out that there is a possible HIV risk, you can prescribe them PrEP to start immediately, which essentially is the same as starting PEP or post-exposure prophylaxis. It is, and it says this in the prescribing tool, it is recommended that you make contact with your local PEP service, and the phone numbers for those are online, just to double check that it's okay in that particular scenario. But I think it's a really important point. Thanks, Bronwyn, for bringing it up, that you can now, and you don't need to be an S100 prescriber, as Trini said, any doctor in Australia can prescribe PrEP. But basically, as a result of that, you can now also prescribe PEP in most scenarios when people need it. The next question is from Luna, who said, for on-demand, if you just take it for 1 day, will it work immediately? Luna, I'll very briefly answer that question for you. So on-demand PrEP, again, is only for cisgender men who have sex with men. And that's not because of any sort of reason that we don't want to prescribe to anyone, but it's because the trial data only comes from that population. The only on-demand, successful on-demand PrEP studies were among men who have sex with men. The protocol is 2 tablets of PrEP, so 2 tablets of Truvada, so double dose, at least 2 hours before sexual contact, followed by 1 tablet 24 hours later and 1 tablet 48 hours after the first dose. And that's 1 course of on-demand PrEP. I won't go into it in more detail because then obviously you need to work out how you go from there. But basically that works, and that works really well. So at least 2 hours before sex. The next question is from Gergis. I hope I pronounced your name correctly. And Gergis asks about confidentiality. If the patient has asked not to disclose his test and it comes back positive and I should notify HIV, what should I do if he refuses to proceed with testing? Trini, do you have any wisdom to impart?
Yeah, sure. So not to disclose if he's, okay, so HIV, there is enhanced surveillance for HIV infections. It's done on a 2x2 code. So the patient's identity remains anonymous or confidential. Also with the testing, the positive test gets sent to be as a part of a notification by the lab. So basically it's done. I think the patient just needs to know that they're de-identified, and it's just the case that's the case and the 2x2 code, a date of birth and
Postcode.
Postcode.
Yeah, and I think that's really important, Trini. Thanks for highlighting that. The notification, the HIV notification, is not in the patient's name. It's a 2x2 code, so 2 letters of their first name and 2 letters of their surname. So if they're really worried about confidentiality, you can often reassure them that their name wouldn't be use. And I would strongly counsel patients to not see that as a barrier to testing, because then they will miss out on HIV testing forever. Let's move on, because oh my God, we've already run to 8:30 and we're having such a good time and we wanted to keep going. Thank you all for so many questions. So here's the resources, which will all be emailed to you. I guess just to wrap this up, and I'll throw it to the panel as well if there's any additional points to impart to the audience. But I just wanted to wrap up and say that what we've really tried to highlight tonight is that PrEP is really safe and it's really effective, and prescribing it is really easy. And for people who are at risk of HIV, it can be one of the most important things that you do for that person ever, if you can prevent them from acquiring HIV. And we particularly need your help in reaching the more difficult to reach populations. So people from culturally and linguistically diverse backgrounds, people who don't identify as gay, people who don't live in the cities, who don't access sexual health centers. The people who access sexual health centers and people who are engaged in the gay community, most of those people are already on PrEP. We've already got those people on PrEP. We really need your help to try to reach those people that we can't reach. And as I've said, and I can't highlight enough, I urge you all to have a look at the ASHM PrEP prescribing tool, because it really does show how easy it is to prescribe PrEP. What we've also tried to highlight is that the suitability criteria for PrEP have been broadened, which means that more people are eligible for PrEP in recognition of the fact that we need to deliver more PrEP in the community to anyone who's at risk of HIV if we are going to achieve our end goal, which is to have no more new transmissions within New South Wales. Another point is that we need to increase access to PrEP for the patients groups that we talked about. Really, that's it. And the resources are going to be sent to you. Now, just to throw to back to the panel, is there anything else that any of you would like to add to tonight's discussion? I do apologize to our consumer participants. I wish we'd had more time to talk to you as well, but it's been quite a rush.
I think just the point that you made, I think the thing is that prescribing PrEP is easy. It can be done by all GPs, and the tools are out there to make it streamlined for us.
Yeah, and I think, sorry to keep talking, but I think, Miriam, the point that you made earlier is really important for people to try to find a way to make sexual history taking a routine part of history taking with every patient. And I think that last bit, every patient, is really important, because people change. People might have been married for years, and then for some reason, you know, for example, a guy might be married to his wife for 20 years and all of a sudden starts having sex with men. Unless you routinely take sexual histories, you won't know that, and he may not be comfortable coming to you to talk about his sex life. So taking that ownership and running with it. In my experience, I've never had anyone object to the fact that I ask them about their sex life. If anything, the reaction I tend to get is one of relief, of people knowing that it's a safe space to talk.
All right, well, I might wrap us up for this evening. Before we go, I just wanted to say a big thank you to our panel this evening. Thank you, Vincent, Miriam, and Trini, and also a massive thank you to Ferry and Paolo for coming here tonight and sharing your experience. And thank you to everyone online who have submitted questions and gotten involved with tonight's presentation. It's really appreciated.